Good morning, everyone. Welcome to our webinar, Changing the Way We Work, COVID-19 Vaccines. We're really looking forward to continuing our conversation on the vaccines that we started a few months ago now with some special guests. I'm Dr. Tara Kiran. I'm the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto, and also a family doctor at St. Michael's Hospital. I'm going to be your moderator today. We're really pleased to bring you these sessions co-hosted from both ourselves, the Department of Family Medicine, as well as the Ontario College of Family Physicians. And so I'm going to turn it over to Dr. Liz Maga to introduce the session.
Good morning, everyone. Delighted to be here, and thanks, Tara. So we've got a great session for you today. As you probably know, if you've joined us before, our panelists will be introducing themselves in just a moment. So I won't go through that now, and you can collect MainPro credits. Next slide. I'm just going to read the land acknowledgement now. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and the DFCM recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous peoples have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I am, as always, calling in from Ottawa, which is unceded Algonquin and Anishinaabe territory. Back to you, Tara.
So we've heard a lot about the vaccine rollout on this call previously, including in Indigenous communities. And it's been great to see the great rollout in the North, but also acknowledging that it's not been the same smooth process for urban Indigenous. And so just putting out here a link to a really practical resource, particularly if you're in Toronto, where it is an Indigenous-run clinic, 2 Indigenous-run clinics that people can access for the vaccine. Next slide. And so as Liz mentioned, we do have a whole set of past sessions that you can watch. Many of these go through details around vaccine effectiveness and safety, details that we won't probably be repeating today. So please do check out our past sessions. These are now also accredited for self-learning as self-learning. So if you do them after it's live, watching the recorded session, you can still get the MainPro credits. Next slide. And I wanted to just give a shout out to our planning committee who always picks the speakers. If you have any suggestions for speakers, please do put them in the evaluation. Next slide. And so today we're really delighted to have people from across the province telling us about their experience with the primary care pilots, and also Dr. Warshevsky joining us again to give us more updates on the vaccines, particularly AstraZeneca. Next slide. And of course, we've got our usual co-hosts, Liz and David. Next slide. So I'm going to turn it over to our panelists one by one for them to introduce themselves, starting with Dr. Sohal Goyal.
Thank you, Tara. So my name is Sohal, and I'm a family physician in Mississauga. I'm currently the chair of the Mississauga-Halton Primary Care Network, as well as I work with Peel Public Health on the Primary Care Working Group for Mass Vaccination, and also chair of District 5 at the OMA. You'll see a number of disclosures there because I've been a moderator for many different pharmaceutical CME type talks in the past, but they have no impact on today's presentation.
Thanks. Sandy, do you want to go up next?
Hi, my name is Sandra Khan. I practice in Peterborough with the Peterborough Family Health Team. I'm also affiliated with the Queen's University Family Medicine Residency Program. My involvement in pandemic planning has been as a member of the Peterborough Interagency Vaccine Task Force, and as well as a member of the Peterborough Vaccine Sequencing Working Group, which led to, I guess, the invitation to participate in this pilot.
Thanks. Next slide. Dan, you want to go next?
Yep. Hi, everybody. Daniel Warshevsky, public health physician with the Ministry of Health in Ontario. Nothing to declare.
Liz?
Liz Maga. I'm a family doc in Ottawa, president of the Ontario College of Family Physicians, and I receive a stipend from the college for my work as president.
David?
Hi, I'm David Kaplan. I'm a family doctor in North York, and I don't have any relationships with financial sponsors other than getting a stipend from the Ontario College for this, and I'm also an employee at Ontario Health, and probably more important to this session than to other sessions where I've been introduced as the Chief of Clinical Quality there. For the last 13 months, I've been the primary care COVID-19 lead for Toronto Region Ontario Health.
Thanks, David. Next slide. So for myself, I, as you know, I'm a family doctor at St. Mike's, and I am a researcher, so do have a number of grants that I've gotten from different organizations, as well as some salary support, which I've listed there. The only one that's from a for-profit company is Gilead Sciences for some work around hepatitis C. Next slide. So we're delighted, of course, to welcome all of you from across Ontario, and your participation here is what makes this community of practice come alive. Thank you to everybody who submitted questions when they registered. Next slide. So your questions really help us guide how we're going to organize the content for this session. So these are really the 5 questions that rose to the top from the ones that you posed. And the ones that we're going to really focus on answering today. We're going to want to know more about the primary care pilots. We're excited to hear about lessons learned from Sandy and Sohal. We're going to know a little bit more about where we're at with the vaccine rollout. And then importantly, there's lots of questions about AstraZeneca, and Dr. Warshevsky is going to go through those and hopefully answer them so that you can feel more confident counseling following this. Next slide. We know that you're going to have questions as things arise, and I just urge you to put those into the Q&A box. The chat is a wonderful way for you to connect with each other, for you to share resources with the community, but we won't be looking at the chat when it comes to answering questions because there's still hundreds of people on this call. We really urge you to also use the thumbs up sign. So if you see a question that you like, please use the thumbs up so that it can advance up, and I will be prioritizing the questions that are at the top that more people have prioritized through that thumbs up. So please take a look out for that. Please also take a look at the answered questions because I know Liz, David, and Daniel are great at answering questions by text, and so just read through them to see if anybody else has already asked the question that you're interested in. And as a reminder, from last session, we've actually posted the Q&A, some of the common Q&A on our past sessions website, which Mina will put into the chat if she hasn't already, as well as Dr. Warshevsky's slides so that you can take a look at some of that detail around variants in AstraZeneca. Next slide. I think our conversation today is particularly timely because so many of us have been so frustrated about the rollout of the vaccines in relation to primary care. We've seen vaccines go in spades to pharmacies, and at the same time, we feel like primary care has been left behind. These pilots were the one chance for us to show that we can do it, and hopefully for us to turn the tide to have family doctors more involved. We know that we can do it. We're a really important part of addressing confidence, and that this is, the family doctor's office is where patients want to get their vaccine. And this was confirmed in a recent poll that the Ontario College of Family Physicians did that was released this week. So just this week, they released this data saying, when they asked people, the members of the public, where they would prefer to get their vaccine, actually the #1 location that people voted for was the family doctor's office, then followed by pharmacy and mass fax clinics, et cetera. So we know through data now that the public trusts us as family doctors. Next slide. And I will say trust is one of the key issues here. So that is one of the big reasons why people want to get the vaccine from the family doctor. They trust us to administer it. We know their health history, and we can look after them in a holistic way. So these are all things that we know, and it was great to see it borne out by the data that the Ontario College put out this week. Next slide. We also at the same time know that giving the vaccine in the office may not be for everyone. And so, as we start this conversation, we're going to put out a poll. So Brian, I wonder if you could start that poll. And we're just going to get a sense from you. Are you interested in giving the COVID-19 vaccine to patients in your office setting? So we're going to give you about 30 seconds to just answer this, and it would just be great to get a sense of the people on the call right now. What portion of you are interested in giving the COVID vaccine to patients in your office setting? And so we're going to try and repeat this poll later on in the session after you've heard also from Sohal and Sandy and had more of a discussion with David and others about what that pilot has really been like. So here we go. So 85% of you, I think there's 627 people on the call, and 85% are interested in giving it in their family practice. And that's just so heartening to hear. And I think a message we've been getting out there that for the most part, we want to do this. It's not for all family doctors, but the majority, we want to do it and we can do it. So with no further ado, I'm going to actually turn it over to David Kaplan to start us off, because David's going to give us a bit of a background on the primary care pilots, why they came to be and why they were structured the way they were. David?
Thank you very much. Appreciate it. So until about, just under 2 weeks ago, the 190,000 doses of AstraZeneca were going to flow directly to just the pharmacies in the province. And through, I would say, the advocacy of many people over the last 8 weeks, including folks like the leadership from AFTO and the OCFP and the chairs of family medicine across the province and the section of general and family practice and the OMA, the ministry agreed to have a small pilot of getting some sites up and running in 6 public health units across the province to distribute AstraZeneca in primary care. And to give people a sense of the magnitude difference, there were 190,000 or so doses. About 30,000 of those doses went to primary care sites in 6 cities, including 7,000 doses that went to Toronto, and the rest of the 160,000 doses went to pharmacy. And so in Toronto, for instance, you had 111,000 doses go to pharmacy and 7,000 doses go to primary care. The primary care spoke, as you can see here on the slide, these spokes were to be identified by public health units and it was really supposed to be a collaboration between the public health unit and the primary care partners to implement vaccine rollout. And you can see there, even in the ministry slide, which I'm using, it says, for example, family health teams. I can tell you that across the province, and you'll hear from some of the other guests, we've rolled this out with public health in fee-for-service practices, in FIGs and FOs, in family health teams and CHC. So I think there's been actually over 90 sites across the province that were identified by public health and local primary care from a variety of different models, which I think is really important, because obviously all of us today on the call, the almost 700 of us, work in very different models, and we need to figure out what are the best practices to learn from each other when we want to scale this across all of primary care. Okay, next slide. Just to give you a sense, this was a pretty strongly governed slide. When the ministry has a slide that comes out to all the sites called governance, and there was really about 24 to 48 hours of notice for the sites to come on board. I know, Sohal, you said it was about 24 hours for you guys to identify all of your sites. And the ministry has been hosting 3 times a week calls with each region, public health, to really figure out exactly how things are going, how to facilitate. And, there was very clear escalation for things like needing to move doses between sites, for instance, or how to get COVAX up and running and training. Next slide. When it came to clinic planning and logistics and oversight, you can see on the readiness assessment, clinics that were picked not only did at least in Toronto, which was a little different than the other public health units. In Toronto, we selected practices that were in FSAs or postal codes that were in disproportionately affected neighborhoods of COVID, and public health actually has a running list of those neighborhoods. And so we used that readiness assessment that you see on the right side of your screen in conjunction with a list of neighborhoods to figure out which were going to be the 12 or 13 sites that we were going to go forward with in Toronto. And you'll hear from our guests, it may be a little different in some of the other areas of the province. Next slide. And then I think this is the other, and I'm sorry it's not, this is a ministry slide, and I'm sorry it's not projecting 100%. But as you can see from the word COVAX, I don't know, must be a dozen times on the slide, it was mandatory that all of the sites use COVAX On, which is the provincial vaccination system for onboarding patients into the vaccine system and also for recording doses. Ontario MD very, very quickly pivoted to support all the practices in training for COVAX, and the ministry also had to really get hundreds of users up and running very quickly with usernames and IDs, and sorting out all sorts of things, like every site needs their own what they call vaccination event, and the doses have to be loaded into those vaccination events. So definitely a lot of admin burden, which I think you're going to hear up front, but not just for the practices, but admin burden for the public health units. And I think some of the public health units were, I think, surprised by the amount of administrative burden to get COVAX up and running in all of these smaller multiple sites. And with that, I think that was my last slide, and we can hand it over.
Thanks so much, David. So I think, we've got a lot of questions in the Q&A, but I wanted to just let the audience know that we're going to start by talking more about these primary care pilots, hearing from Sohal and then Sandy, and then following that, we'll have Dan Warshawski tell us more about the AstraZeneca vaccine. So hold your horses about that. So I'm going to turn it over to you, Sohal, to tell us, an on-the-ground story. You were one of the primary care pilot sites. You actually helped to organize this for your region as well. What was your experience like, and what can we learn from it?
Thank you, Tara. So of course the challenge is here, right, everyone? Can COVID-19 vaccines be given in a regular family practice? Next slide, please. We started at the region of Peel with a partnership really that had formed in January with the OHT, local OHTs, the primary care network, and we formed a primary care working group. And so when this was presented, we had a very short turnaround time, as Dave mentioned. We have 10 sites in the region of Peel, and there are all different practices, FIG, FO, CHCs as well. And we were initially given 4,500 doses, which then increased by another 1,500 for a total of 6,000. In terms of our practice, it's in Mississauga. It's a fee-for-service FIG practice. We have 5 physicians, 11 staff, 6,000 rostered patients, and we have a walk-in clinic as well, which is kind of important in terms of our site, in that we wanted to open it up to the community because we already serve the community 7 days a week. Next slide, please. There's a lot of logistic challenges. First of all, there's self-doubt, as we all generally have. But looking at how the vaccines have been rolled out in other areas or other partners, like our hospital partners, we were told that it was very resource heavy, 6-to-1 to 10-to-1 ratio from staff to vaccinators. So that was the first challenge. Secondly, there was a major time crunch, as was already mentioned. On Sunday, March the 7th, the region of Peel held an emergency meeting because they were a last-minute addition in terms of the pilot sites. We met twice a day as a primary care working group for the next 2 days. On Wednesday, the sites were confirmed. COVAX, we put our staff into COVAX on that day. We reached out to Ontario MD on Thursday, but Ontario MD was still onboarding. And we had the understanding that we had to start on Friday, March 12th with vaccines in arms. So that was a major time crunch. What we faced in our practice was recruitment of patients. How do we let our patients quickly know, as we found out Wednesday night, that we have vaccines starting Friday? One of it, we use Oscar in our office. So we hadn't really leveraged our EMR in the past. We did a query. We got our staff to start calling patients, but then we also did a couple other things with our website, which I'll quickly go through. IT is always an issue. We're a small office. We don't have an IT department. It's basically our office manager, a couple of the physicians who do most of the lifting there. Infrastructure is always a challenge, especially HR, our human resource aspect, the physical layout of the clinic. As we all know, when we compared to a flu shot, it's quite a different process in that you have to, physically distant due to the pandemic, and then post-vaccine, you're monitoring for 15 to 30 minutes. We had to address vaccine hesitancy, which of course is always a concern. And the first challenge we had was on Friday, March 12th. All of the data in terms of blood clots came out that morning, and we already had patients booked that afternoon. The consent aspect was another challenge. How do we obtain consent, find if there are patients, which we know well and we have them in our EMR, but how do we obtain consent from patients that we've never met before? And then, of course, maintaining our practice at the same time, which is a challenge as we're giving shots. Do we do it as a mini mass site, or we do it while we're doing our practice? And we decided to first start by doing injections while we're doing our practice. Next slide, please. So this is our website. We changed it on Thursday night with our vaccine starting on Friday. We added that book COVID-19 vaccine button there so that anybody in the community could go onto the website and start booking. Next slide. And part of the reason we did that was frankly because we contacted some patients and some of them put it on WhatsApp, and that went to neighborhood groups prior to the Friday, so on Thursday night. And I was notified by a friend who happened to be notified through WhatsApp that we were getting the vaccine. We were trying not to publicize it. And sure enough, Friday morning, our phone lines were jammed with people asking about the vaccine. So this is the second page. The first link goes to this page. You can see a Google form document. Again, we built that Thursday night. We did not know anything about Google Forms. Next slide, please. So when patients click the link, they get this vaccine, COVID-19 vaccine appointment request form. And it's just some basic information that then automatically goes to Google Forms that we can tabulate. Next slide, please. And from there, we go through that list, and then we send patients this consent form. Again, it's a Google form document, so we can keep track. Next slide, please. And we go through each of the questions. And so this is the consent form. It's directly from the ministry. We copied the questions. We added additional questions such as how they heard about the vaccine, just to try to keep track. And also there was specific criteria, as David mentioned. Initially, it was those only aged 60 to 64 in the community. Next slide, please. And this is our physical infrastructure, our layout of our clinic. So that's our waiting room. So we separated two areas, one for our walk-in patients or family practice, the other for only COVID-19 patients on the right. Next slide, please. Our office has 9 exam rooms, and so we have 2 long hallways. Next slide, please. And as you can see, we have an external exit that we used. Now, one of the challenges, of course, is the post-vaccine time. We didn't want patients going back and forth from the exam room to the waiting room, especially as we had patients coming in. So the model that we adopted was bringing patients directly into the exam room, checking them into COVAX, and making them wait 15 minutes in the exam room itself, and then exiting, and of course, then disinfecting the rooms. And they could exit directly from the back door there, so it's unidirectional flow. Next slide. And our current flow, we're still running our family practice. And when we're running family practice, we can actually do 2 to 4 injections per hour. In terms of the times where we don't run our family practice, so after hours or after we're finished our regular shift on the weekend, we can run about 12 to 14 shots per hour with 1 physician and 2 staff. So after that initial heavy lift, we've now become quite efficient in terms of COVAX. And of course, COVAX was a challenge for us in two aspects. One was none of us had used COVAX, none of us had registered for COVAX, so there was a lot of anxiety around that. And secondly, we had an issue in terms of our computers. They were a bit older. We couldn't load COVAX into our browsers. So we actually have two computers side by side, one running our EMR and the other one running COVAX at the same time. So thank you.
Thanks so much, Sohal. And apologies for the technical delay around the slides. We had a bit of a PowerPoint crash in the background. So yeah, incredible that you've been able to do this in, what's a very busy family practice and walk-in clinic in a fee-for-service setting without a large team. And so I think there's a lot that we can learn from that. There are, some questions, I guess, that people had about COVAX. How can we? I think Ted Mitchell asked, the current excessive paper-based consent forms are insane, as is the clunky COVAX system. How will we deal with an office vaccination process, which is 10% needles and syringes and 90% administration? And I think you really helped to illustrate how we can do that by trying to be efficient with the way that we collect information in advance and streamline our processes in the clinic. I don't know if there's anything else you wanted to add to that, Sohal.
Yeah, as you mentioned, Tara, it is really heavy on the back end, and it's collecting that data and then attaching it to the file, and also still contacting patients. That's what we're struggling with right now. So just to give you an example, we have 1,200 requests. We only have 530 vaccines, but with the vaccine hesitancy and as the region is opening up more slots, we are finding some patients canceling. So we had to have dedicated staff, which were already stretched thin, to make calls. And so literally it was all hands on deck. I have my kids helping. Today my wife took the day off work and she's calling patients, just because there is lack of human resources in terms of the practice itself.
So,
and Tara, I posted.
Oh yeah, go ahead.
I was just going to say I posted again, like I think Sohal spoke about the use of technology. I posted one of the clinics that set up something like a Google form, so people can get a sense of what that looks like. It's in the chat, and that's how they're dealing with the admin burden, is to get the patients to self type in all the information, and then that's being uploaded to COVAX before the session goes live, like the clinic.
Yeah. So Christine Tai asked, can anyone comment on the financial cost of running an immunization clinic in the primary care setting? I don't know, Sohal, if you wanted to take that.
Yeah, it is challenging. We haven't done the numbers crunch to see whether or not we broke even, and that's the goal here. We wanted to break even ideally, and I think to some degree from the financial side, it's a bit easier in a fee-for-service family health group practice, in that most of the time we are billing a visit, a minor visit, because inevitably we are asked a lot of questions. One thing we discovered early on was to keep those doors open for the exam rooms, and we're quite loud when we're answering questions, and it becomes a little bit of a party in that patients are asking questions as we're in the hallway, and we're answering multiple questions as we're walking up and down the hallway. Plus, this way it's easier for us to monitor everyone. But I do think that you can survive, you can do well. Is it financially worth it? Are you doing it for only financial reasons? I don't think that would be the case, no. It's a community service that you're doing, but I don't think you're going to lose money doing it.
Thank you. So I think there's a lot of great shout outs to you in the chat there. So people really appreciate you sharing your story. I'm going to turn it over now to Sandy Khan, who's going to share her story. Brian, I don't know if the slides are working, if you're able to bring up Sandy's slides.
Okay, Tara, thank you for inviting me to talk to you about the Peterborough Experience. I'm a member of the Peterborough Family Health Team, which actually is an umbrella organization that includes 5 different family health organizations and 2 nurse practitioner-led clinics. All of the over 90 family physicians practicing comprehensive family medicine in the Peterborough area belong to one of the 5 family health organizations. We have an extensive number of allied health professionals that support our practices, including pharmacists, nurse practitioners, and RNs. We have an extremely supportive executive director who, I guess, backed us up on this pilot by helping us with redeployment of human resources, and also provided some additional funding to help us stay revenue neutral. It's important to note that 2 of our family health organizations are actually physically located within multidisciplinary physician clinics that actually have on-site IT support and an administrative team. 3 of our FOs, though, are composed of family physician offices that are distributed throughout various sites around our city and county. And PFIT, as we affectionately call it, provides care to 108,000 patients in our area. Next slide, please. So I thought it would be helpful for people to sort of know what the timeline has been, because it really speaks to, I guess, how much work needed to be done before we actually launched our clinics. So it started on March 5th, which was a Friday evening. And when I got a call from the medical officer of health asking whether primary care would be interested in participating in a pilot. The goal of the pilot was to deliver 4,500 doses of AstraZeneca by April 2nd, which was when these doses were due to expire. So a late night huddle on a Friday evening, which can really only be done in the middle of a pandemic, was convened with a few other sort of primary care leads in the Peterborough area. And we decided to take this huge leap of faith and just jump on board. And we needed to let our medical officer of health know our answer by 10 a.m. on a Saturday morning, so she could relay that to the ministry. And I should also let you know that she was actually very clear from the start that public health would really be able to offer us virtually no support, because they were consumed with the launch of their own mass vax clinics a week or 2 later. So on March 8th, we got each FO identified a vaccine clinic lead. This was a very important role because this person was doing all the planning, the logistics, the infrastructure, the staffing. They were organizing all of that on their own time outside of clinic hours. We identified an inventory manager. This was going to be the person who was liaisoning with public health about, I guess, their allocation of vaccine. And during clinic time, they have to reconcile and account for each dose administered, and manage what we called our overflow lists, or our last call lists. And our IT leads were critical. So at the beginning of the week, each of the IT leads were in the process of contacting Ontario MD regarding COVAX onboarding. We got off to a little bit of a slow start because Ontario MD had just gotten the contract by the time we were talking to them on Tuesday or Wednesday of that week. And the vaccine arrived at our public health unit at the end of that first week, March 12th. And yes, on the part of the ministry, there was great expectation that we'd be ready to deliver vaccine by the following day, which at that point, we hadn't actually even started the training or the onboarding process. So over that weekend, the weekend of the 13th, 14th, Ontario MD was hosting multiple training sessions throughout the weekend. And so that's when our clinic staff and our vaccinators and inventory managers and super users were getting trained, was over the weekend. Starting early the next week, that's when our onboarding was occurring. Again, this was something that our IT leads were fairly critical in establishing for us while we were still working in our practices. So we probably onboarded well over 200 people in the space of a couple of days. Then the IT lead would coordinate with the public health unit for the creation of the vaccination events and linking all of the COVAX on users to the appropriate vaccine event. Our first clinic launched March 17th. This FO decided to use an evening and weekend clinic administration. So they were running 7 days a week. And this was a clinic that was running in parallel with their already existing after hours clinic, because they didn't feel that the volume of their evening clinics and weekend clinics would allow vaccine administration as well. So by the end of that weekend, we now had 4 vaccine clinics in operation, and we managed to deliver 2,300 doses via either a mass or mini mass vaccination clinic model. Going into the last 2 weeks of the pilot, we still have 2,200 doses, but now by now our delivery will be combination of mass vax clinics and in-office administration. Next slide, please. So the lessons we learned, well, they were many. We learned that we're able to deliver or administer a large number of doses in a very short period of time. Our patients reported being very highly satisfied with the mass and mini mass vaccination clinic model within family practice. The physicians enjoyed the vaccinator role, and they enjoyed participating in the mass vaccination clinic models and mini mass models as well. And particularly for our FOs that were distributed throughout our area. The good news is now all our potential vaccinators and clinic staff are now on COVAX On and can use this going forward to administer in their offices. And overall, most people would say that it was a very rewarding experience overall. There are some downsides, and as people have already mentioned on the call, I'm just going to reiterate, it's a very large administrative burden. Our vaccine leads spent countless hours on planning the logistics and operations and staffing of the clinics. Our office staff spent countless hours contacting and booking patient appointments in our clinic EMRs. And our IT staff basically dedicated a whole week to getting everybody on board on COVAX On, linking with public health unit with respect to the creation of the vaccination events, and then uploading all the patient data from the clinic EMRs to COVAX On prior to the clinic days. The inventory manager role appears to be a bit of an intimidating, labor-intensive role, and maybe that's just because we're early on in the project, and you know, as we get more comfortable with the role, it'll become a little less intimidating. We have not yet run the finances and confirmed the final budget. At this point, we're just hoping to break even. The big concern amongst all the vaccine leads is that the evening and weekend clinic administration model, we're concerned how sustainable that will be for the long term over the next several months that this pandemic. Next slide. So it is a pilot and it's something to learn from. So at the end, we will be meeting as a group and trying to answer the following questions, like how do we administer these vaccines in primary care in a sustainable and financially feasible way over the next several months? And how are we going to create time in our daily workflow to deliver a meaningful amount of vaccine to our patient population to help prevent our patients from getting sick from COVID? And I'm just going to conclude by saying, when we got the ask on March 5th, you know, in the discussions with some of the leads, it was like, well, we do vaccine clinics every year. We know how to do this. We know how to identify the population. We know how to reach out to the population. You know, we can do this. And I think the conclusion amongst our vaccine clinic leads is this is not the same as the flu shot. There are a lot of different components to delivering a COVID vaccine. we've learned from it, and we're hoping to be able to use our lessons and develop a more sustainable model. Thank you.
Thank you, Sandy. So I think, like Sohal, you've helped us to demonstrate how family doctors have stepped up across the province. I think Lee Donahue said something in the chat that family doctors are experts in roadblock management. I think Alan Grill, talked about how we're doing all of this in addition to seeing patients that we need to see in our usual way as well. People have been commenting, doing virtual care and alongside the vaccines is one way to help keep it safe. I'm going to read out a few other comments from the chat because I think there are other people in the chat who have also been participating in these pilots. And hopefully over time, we'll have more people join this community of practice to share their story. But Harry O'Halloran up in Simcoe Muskoka talked about drive-through clinics as a really great innovative model that we can start to think about. Jordana Sachs at North York talked about the importance of volunteers, especially students who are very tech savvy and can help to enter data into COVAXon. I think Heather Klopp was talking about sort of a train the trainer model where one nurse gives it and then the other was watching. So in a way to increase your staff capacity. And then, there's obviously comments in the chat as well that we have many roles to play here in the pandemic. And so, yes, not giving it in our offices is one of those many roles. We also are helping support mass vax clinics, educate, et cetera. So some wonderful comments and discussion in the chat that's really building on what Sohal and Sandy have shared with us today. I'm wondering, David, if you wanted to just speak briefly about to add on to Sohal or Sandy's comments. I also do want to make sure we have some time for Dan to go through his slides for AstraZeneca.
For sure. I think all I would add is that it's really important, and there's a comment about why did we need to do a pilot? We give flu shots all the time. I agree with that. Believe me. That being said, I think what we've learned in the last 2 weeks from across the province, and even within one city like Toronto, is that we need to figure out how to do this in different practice settings. That all of us work in this, variety of different settings, and so even in our own practice, where we did it, the first weekend and week that we did it, even though we're in a FO, we did it with none of the family health team staff. We just did it with our own office staff and volunteers because we thought it was important to figure out how do you get this done without additional resources. And I think Jordana, who I work with, made the comment about the power of volunteers. The volunteers aren't just great because they're there and it's a health human resource. They're there because they're also great because they were very helpful at alleviating people's concerns. Right? They were walking people from check-in to the room, and they could sort of just have a chat with people and alleviate their concerns, not their concerns about specific questions about the vaccine, but just the anxiety they have about going to a space. Many of these patients haven't gone into a public space with this many people for a long time. And so there was a lot of just that natural kind of relaxation, getting the right volunteers with the right voice and manners, which is so important.
Thanks, David.
I would say the other thing, and it was in the chat that I just want to draw attention to, is that not only were there so many more vaccines given to pharmacies, but the location, and I posted an article in the chat where they mapped out all the pharmacies in Toronto that gave vaccine, and in all of the neighborhoods where, the top 5 neighborhoods, there's not one pharmacy that was giving vaccination. And I think in neighborhood number 6, which is Engle Mount Lawrence, they've done so well there that they'd already gone through 500 doses, and we've given them another 300 this week. So I think it is the power of primary care to get at the right communities as well.
Yeah, so there's an equity lens that we bring that hasn't been brought to date from some of the other distribution methods. One question to you, David, before we go to Dan, I noticed you wanted to ask was, Can anyone comment on whether COVAX will
COVAX.
be able to notify
Yes.
family doctors when their patients get vaccinated? So Jennifer Tran asked that question.
Yeah, that's right. And so I wanted to make sure that we address that. So the plan, from my understanding and speaking with the folks at Ontario MD, is that at some point in April, there will be a push notification similar to the way that we get a push notification when a patient gets swabbed for COVID-19. And that's how you would get the information into your EMR.
Thank you. So Brian, I'm going to ask you to bring up Dan's slides, and Daniel, I'm going to turn it over to you because there's lots of questions about AstraZeneca and the clotting in particular, what we should be telling patients, which of our patients who have a history of clotting should get it and whatnot. So I'll turn it over to you, and also I guess you can give us a very brief update about what we can expect.
Yep, thanks, Tara. So the first couple of slides here are just what we have in terms of projection of doses that are going to be coming into Ontario. So this is for Pfizer. We have a really good projection of what's coming in, roughly 400,000 doses a week, every week until the end of May. So we're really confident in that one. Next slide. This is the Moderna projections. It's a little bit more up and down, and they only come on a bi-weekly schedule, but these are the amounts that we are expecting as of right now. And we are also expecting this to get a little bit more regularized as we get closer to April. In terms of AstraZeneca, it's not completely clear right now how much is coming in. We haven't heard about that 1.5 million coming from the US yet that was promised by a handshake between the Prime Minister and the President, but hoping that it comes very soon. In the meantime, the doses from coming from the India Covishield one are a little bit on hold because of some of their exportation problems due to their increasing cases. So, we're expecting for the country roughly 1 million doses over the next 4 to 6 weeks of AstraZeneca, but it's not entirely clear exactly when and how much is coming in. Next slide. So we'll do a quick run through now of AstraZeneca recommendations. So number one, NACI expanded their recommendation for the use of AstraZeneca to everyone over 18. So their first recommendation was that it should be essentially 18 to 64, and they were not suggesting that it be administered to individuals over age 65. Based on the data that we got primarily from the UK, they've given out more than 10 million doses of AstraZeneca that demonstrates the safety and effectiveness in the real world setting. They modified the recommendation that AstraZeneca is now something that can be considered for anybody. And Ontario has since followed suit and obviously opened up our AstraZeneca administration to anybody over the age of 60. Other provinces are doing things a little bit differently. Some of them are actually started with young essential workers anyway, so it's not making a difference for them, but at least in Ontario, it's been really helpful for us to be able to open that up to a much broader section of the population. Next slide, please. So we'll get into the exciting stuff now that I know everybody wants to hear about, the clotting issues. To start off, the Ontario Science Table is working with OCFP and the Centre for Effective Practice to get a number of materials out for patients and providers and vaccine sites, really clarifying everything we know about AstraZeneca and this issue, which is being called vaccine-induced prothrombotic immune thrombocytopenia. It's related to HIT, even though obviously there's no heparin involved, but in terms of it being kind of an immune-mediated thrombotic response. So those documents from the science table through OCFP and CEP are expected to come out early next week. So I'm basically giving a short sneak preview and scooping the science table, and hopefully they aren't mad at me, but they put stuff out all the time without telling anybody, so it's fine. What we know so far is that these are still very, very rare. So in the numbers that we have to date, the incidence is somewhere between 1 in 200,000 to probably 1 in 1 million. It's not narrowed more than that, but we are watching very closely. It is certainly more common in women and more common in individuals under 55, which thankfully for Ontario means that we don't particularly have concerns. And I should be clear, it is not just more common in people under 55. In the over 55 age group, there was no difference compared to background levels of these conditions occurring. The primary condition that arose was CSVT, or cerebral sinus vein thrombosis. That was happening 4 to 20 days after vaccination. There was no increase of rate in that in anyone over 55. It was all in the under 55 age group. To date, there have been no cases reported in Canada of anybody having these concerns. or APHIS reported. So next slide. Health Canada just updated their product monograph on AstraZeneca to include these very rare events and continue to emphasize that the benefits of vaccine needs to be compared with, weighed with the risk for every individual person. But at this point, with such a rare event, it is still continuing to be promoted as something that should be used. So that I have just a little quote from the Science Table Advisory coming out, which is that, this is an immune-mediated response. An individual with thrombophilia, family history of blood clots, or personal history of arterial venous clots would likely not be at increased risk of this particular condition. Again, this is immune-mediated. It does not follow the clotting process that we expect for someone who has an underlying condition to have it. So there are no new contraindications to receiving the AstraZeneca vaccine. Next slide, please. This is part of their diagnostic criteria that will be coming out from the science table. I'm not going to run through it in detail because I don't understand some of it, but essentially for suspect, presumptive, and confirmed VIP-IT, which is what this is being called, these are the criteria to #1 diagnosis and what lab tests we would want to have done in order to confirm this is something that's actually happened. Next slide, please. Oh, that didn't come out well. Sorry. This is the algorithm that will be coming out again with the science table documents very, very soon in terms of how to diagnose VIPT and what should be done. Again, I won't go through right now, but just so that everybody knows it is coming and it is very, very helpful. And the next slide, please. And so finally, this is treatment for patients who have this. So no heparin, no platelet transfusions, first-line blood thinners, consulting with your hematologist, and IVIG. This is the recommended treatment that's going to be coming out. Once again, we'll continue to emphasize that all these documents will be coming out very, very soon, so please do not be relying on my slides here to be doing anything. And again, this is not something we expect to see in Ontario really anytime soon, as we are not administering AstraZeneca vaccine to the patients who would be having this adverse event occur to them. So I'm sure there's still lots more questions on that. And I will just continue to promote that the documents are coming out very, very soon.
Thanks, Dan. So Brian, I think you can end the slides. I just want to confirm then, because there's a couple of recurrent questions. So Shalini Rastogi said there are constant concerns by patients who are at higher risk of thromboembolic episodes. So for example, they had a previous DVT, a stroke, or a pulmonary embolus. They have concerns about receiving the AstraZeneca vaccine, and they're asking letters from us as family doctors to say that they actually should be able to receive a different vaccine, not the AstraZeneca. So how would we, my understanding from your talk right now is that those people are able to get the AstraZeneca vaccine. It's not a contraindication. Any recommendations on how we should handle this situation?
Yeah, thanks, Sarah. So exactly. Other prothrombotic conditions are not a contraindication to receiving the AstraZeneca vaccine. It is through an entirely different pathophysiological process that this occurs. So the #1 thing I would do is be very reassuring to your patient that they are not at increased risk of these events because of that underlying condition. To be clear, if people are not currently prioritized for a Pfizer mRNA vaccine, there is no letter outside of having a very clear anaphylactic reaction to the other vaccine or exception that would permit anybody to change and put them sooner in prioritization. So just to make that clear as well, unfortunately, these exceptions can't be made on an individual basis. The prioritization framework was made with a lot of considerations in mind on individual patient risk, those at high risk of severe outcomes, exposures, as well as an underlying ethical framework, all of which are available on the Ministry of Health website if you would like to peruse them and get more familiar with how it was done. It's probably helpful to help counsel your patients if you're familiar with it. But at this point, #1, I would reassure them that they are safe to get that vaccine.
Thanks so much, Danon. So another question by Colleen Chung is, can you comment further about holding the AstraZeneca vaccine or not giving it to women aged 20 to 55? And this is perhaps increasingly relevant as we're moving into phase 2, where we have people who are essential workers or people with chronic health conditions. And then we also, of course, have people who are healthcare workers who are probably in that age group who are currently, I think, eligible for Pfizer and Moderna. But what should we be thinking about 20 to 55, those women 20 to 55 in AstraZeneca?
Yeah, so part of the tools that will be coming out from the science table, and again with the help of OCFP and CEP, are going to get basically how you can counsel patients specifically on that. You know, the number one thing is these are still very rare events. Like I showed, it's somewhere between 1 in 200,000 to 1 in a million. So it's not likely to be an absolute contraindication for anyone in that age group because that's still very uncommon. What we would say is that it needs to be part of the counseling process, that this is a risk at that level. And, you know, that at that point, the discussion should be made and decided with your patient on, you know, number one, what is the risk of COVID, which is highly prothrombotic in and of itself. And we know that it also leads to, you know, not the exact same process, but a similar immune vasculitic type prothrombotic reaction, and is likely, you know, more dangerous, frankly, than the vaccine from what we know so far in terms of COVID-19. So, but that really needs to be a decision that's done with counseling for that individual patient at that level. And that's what we'll expect the science tables and materials to really help out with when they come out.
So there continue to be a lot of questions in the Q&A about the 4-month dosing interval. So I'm just going to summarize a few of them. So I think some people are like, you know, why are us as family doctors, why are we having to wait for 4 months? Can anything be done about that, especially since the people who are, you know, made the change to 4 months, and I'm paraphrasing a question here, many of them got their vaccine dose within the, you know, 21 to 28 day period. So I think somebody's, you know, calling out what they feel is an unfair situation. I think another person commented, so Marco Accardo said, if delayed dosing is acceptable for the community, why is the recommendation for nursing homes, senior lodges, Indigenous still 3 to 4 weeks apart? Isn't the high risk living at home worthy of that 3 to 4 weeks as well? There are a lot of questions about the studies, and that the studies go out, I think, for 2 months, but not 4 months. And so, you know, what is the basis, the evidence base that is justifying this delay in the 4 months? So over to you, Dan, for those tough questions. And I will just say, David and I think have answered some of that in the answered section, but so you can take a look at some of our postings in terms of articles, but I'll turn it over to you, Dan, for a more in-depth response.
I should look at your answers really quickly. No, thanks, Sarah. So the 4-month dosing interval is based on, and actually, so Ontario has put out, and I hope everybody has received it. I'm pretty sure we push it out through OCFP and every other group, a pretty comprehensive document on the decision behind that 4-month interval, including the evidence base for it. So, you know, it's a combination of looking at the population health protection that we can provide by having more people vaccinated within first dose individually, as opposed to holding doses for a second dose. And certainly we know that we can get more protection overall for the population by doing that. But also the studies that we have, number one, for the vaccines currently available, they do go from 2 to 3 months in terms of vaccine efficacy. From real world data, we have more that sometimes are going out to 4 months, depending on the country that it's from. So there are a number of cases that presented that still show good rates of immune protection at that point, as well as basic principles of immunology that we have. So we know that having a longer first dose to booster interval of 12 weeks or greater generally provides better protection. So you think to our normal vaccine schedule, we're not concerned if someone gets their second dose late. We don't really make them double up on it. Again, we're not talking about something for post-exposure prophylaxis. That's obviously different, but for your general vaccine schedule, it's really getting your vaccine early that we're concerned about, and then not giving the immune response. Later is likely to just give you as good or better immune response than otherwise. So we really don't have concerns about the 4-month interval. As to why certain groups have those exceptions, so it's really the very highest risk groups. So, you know, Indigenous individuals in senior lodges, so equivalent to long-term care retirement homes and operational remote immunity, as well as residents in long-term care retirement homes. We know that these are the highest risk people in the province, frankly, for having severe outcomes from COVID-19. So that's why those individuals were chosen to continue on the same schedule, as well as particularly for Operation Remote Immunity. There's operational considerations that it's really hard to change how those helicopters are flying around. But what I will say is that we're actively working right now and expect to have some additional exceptions based on medical comorbidities to that 4-month interval coming out either later today or this weekend. So, what we've heard very clearly is particularly for highly immunocompromised individuals, such as recipients of transplants or patients on active chemotherapy for cancers, that group has a very poor overall immune response to a first dose. They have a poor immune response to the second dose as well, frankly, but they really need the maximum level of protection that we can provide as early as possible. So the Vaccine Clinical Advisor Group that's advising the ministry on which particular dose intervals and the special populations and what their concerns are there has put some initial recommendations forward to the government, and we expect to have those out very soon, and those particular groups suggesting they should have a shorter dose interval. I will say that, just to be clear, there will be no other exceptions other than what comes out officially. So there's not going to be things on an individual level that will allow people to advocate, frankly, that my one patient here, for whatever reason, should get a shorter dose. Unfortunately, there's not capacity to review every single recommendation that way. And overall, these questions all come in as a whole to the ministry, and the Vaccine Clinical Advisory Groups looks at all of them. And, if something needs to change, it comes out as a change in policy overall. I hope that helps a little bit.
Thanks, Daniel. So as we're getting ready to wrap up, Brian, I wonder if you could post our poll again, because I'd love to see how people are, what people are thinking about whether they are interested in giving the vaccine in their office setting after hearing now from Sohal and Sandy. So if you could take a few seconds to just answer this poll. Are you interested in giving the COVID-19 vaccine to patients in your office setting? And then Brian, maybe you can bring up that second last slide, and I'll just speak to it as people are answering this poll. So there have been a lot of questions about AstraZeneca, the 4-month dosing interval, other things as well. We answered many of the questions. I think there are 70 type responses in addition to many of the live things that we talked about. But if you didn't get an answer to your question, stay tuned for our next session as well. Please consider watching our previous sessions. And then finally, so those ones actually have many of the topics have already been discussed, including vaccine confidence and the issues around the 4-month dosing interval. And then I'm also going to draw your attention to our free COVID-19 vaccination modules. We're updating these, and in the next few days, we'll have a new module on emerging topics, including the dosing interval, the variants, as well as what to do after vaccination. So it looks like the results of our poll are in, and I think we started off a little stronger with 85% of people saying that they really wanted to give that vaccine in their clinic, and now I think having heard that it's not straightforward, there's a lot of administrative burden. I think we're now at 63% saying it, but that's still a lot of you out there who are really keen to participate this way. And of course, Brian, you can go to the next slide. Of course, we know that there are a lot of ways in which we as primary care doctors can help out. So delivering vaccine in our office is one of many ways. We can educate, inform, counsel our patients. We can also help in the mass vax clinics and the other things that are happening. But I'm very hopeful that over the next few weeks, we're going to see a greater role for the family doctors who want to be able to deliver in their practice. I think what we heard today from Sohal and Sandy really speaks to our ability to be able to do that in a variety of different settings. And I think we're going to continue to play an important role, especially as AstraZeneca rolls out, and we're looking forward to some of that science table advice that will be coming. So stay tuned for our next session, which is going to be on April 9th. Check out our past sessions, as I mentioned. You can also go to the CEP or the OCFP website for more information. In the meantime, I just wanted to thank all of you for the great work that you were doing supporting your patients to get the vaccine, but of course in so many other ways during COVID as well. So thanks to all of you. We know family doctors are strong and are a huge part of this response. Thank you.